introduction to this forum. He's the former chair professor of the Department of Medicine in Faculty of Medicine, and he has done so much work on geriatric medicine. And he was the former president of Gold Medical Association and also the Sri Lanka Association for Geriatric Medicine and Osteoporosis. And he had been the chairman of the Board of Medicine and also the Dean of Medicine, Faculty of Medicine, University of Rome. And I had the privilege of being trained under him in my registrar period and before that.
Thank you for the introduction, and I still remember the period that you served as a registrar in our ward and picked up the pericardial effusion in the bed number 8, just clinically by purpose in the heart. I still remember the situation. Thank you. And first of all, thank you very much for the SLMA for giving me this opportunity. And my presentation is fairly brief, and then it's basically on the policies. Long time ago, we had this geriatric symposium in, I think it's probably to CCP, and on the other, next year we had a respiratory symposium running parallel, and the audience was divided like 2% and 98% like. So we had only about less than 10 people in the geriatric symposium. So we can see how much importance given for the geriatric medicine in Sri Lanka at that time. And also I'm quite impressed with the achievements of the two countries that I visited. One is in Malaysia, the geriatric medicine advancements, the achievements that they had. And also in Thailand, I think Varsha and myself, we went to this particular Center of Excellence in Geriatric care in Bangkok. And when the patients are wheeled in, and the patients are taken to one side, and the caregiver is taken to the other side, and they both are briefed actually. So while the patients get assessed medically, and then the caregiver is briefed about the management of that particular, whatever the condition. So that was a nice the model that they had in order to improve the quality of care of these patients. So geriatric medicine, I think the concepts at the very beginning was like, what I call geriatric giants, there's several, this is not limited to this, and there are many things, conditions that people talk about. And for many years, when you think of, let's say, geriatricians, here people thought about falls and the dementia and the incontinence of urine and the feces and things like that. And the role of the geriatrician at that time was very much what's called comprehensive geriatric assessment, which is a cornerstone in the management of patients with the geriatric age. And the managing chronic diseases, understanding the diverse presentations that the diseases can have, and also palliation and end-of-life care, and the rehabilitation and functional improvement. So those are the ones that the geriatricians were sort of, were thought to sort of, consider that they are good at. But now we know there are areas which are evolving in the 21st century, and the effective communication, empathy, compassion, patient-centered care, and the shared decision-making. The list is long actually. And then going up to what's called health technology, and then I'll be talking about the health technology a little bit, how they come into the forefront in the management of older people. So topics I will cover in this one are selected areas that are evolving in the geriatric medicine, and where are the role of the geriatricians, and then in the let's say preventive as well as curative care systems, and where he sits in the middle of these evolving scenarios. And then what is his position in the care team? So I will talk about the complexity of the diseases and health of all the people, the multimorbidity and the medication management, the health technology, and also what's called shared care models some countries are practicing. I'll skip that because the first speaker has covered that comprehensively, same information. When you look at the what I call the prevalent diseases in old age, and there are many, and then only thing is that one must realize that in a given patient, it is not just one disease. Let's say a younger patient coming to the clinic maybe had only one disease, or maybe just 1.5, in average. But when if you take older people, it is something like 4.3, average number of diseases, and So they are not single disease, they don't suffer from single disease entity, and they suffer from multiple diseases running at the same time. And the whole concept of this is encapsulated in the concept called multimorbidity. And we talk about multimorbidity more than comorbidity, which is coexistence of two or more diseases, chronic diseases, in a given patient. And a study done in 2013, analyzing 31 million data covering 15 prevalent diseases, chronic diseases, they found that average 67% prevalence of multimorbidity. And what is notable is that the multimorbidity prevalence actually increases with age, like 50% in people under 65, and about 62% in people aged 65 and 74, and when people above 85, and it's almost like 82%, and people have multimorbidity. And also we know the multimorbidity associated with many bad health outcomes like risk of death, disability, poor functional status, and the poor quality of life, and also adverse drug reaction, because there is a link with many, let's say, polypharmacy. Now, even if you take, let's say, chronic diseases and multimorbidity, and multimorbidity has a lot of interactions with other kind of the factors. Some of them are what are called age related. For example, while you are having multimorbidity and those people are frail and they have geriatric impairment, like let's say maybe sarcopenia, and also they have a functional disability. So this multimorbidity occurs in the middle of many factors which are age related. But then it goes beyond those age-related conditions, like let's say socioeconomic factors and organizational factors and many other like cultural factors. Like there are many other determinants in the society operating, and which will kind of influence that multimorbidity. And this concept, what is where the multimorbidity interacts with other factors, which are some are age-related, some are not age-related, and is encapsulated in the concept called care complexity. The care complexity is the multifaceted nature of the patient's need that can make providing care challenging. Right, so patients, not that they come with hypertension, diabetes, and dyslipidemia, and they occur in the scenario of many other factors operating in the same patient, like patient having multiple falls, and then having cultural, let's say, food taboos and the food various restrictions and all. So there are quite complex situation and challenging for the geriatrician. And this care complexity individual factors, they differ from scenario to scenario. For example, in hospitalized patient, it may be different from the people who are in the community. And this particular study looking at the individual factors of the care complexity, and they found that these are the what I call the comorbidity, mental and cognitive impairment, psycho-emotional. There are factors, but then if you go to the community and assess these what I call care complexity individual factors, and they can be completely different, because then there's a completely different set of factors operating at that community level. So health professional carrying forward adults should understand that the medical issues are not the sole factors of care complexity, and then there's an interaction, substantial interaction with these, and also that what happens is that they affect the family caregivers, providers, and the healthcare system, and therefore society at large. What about interventions? The interventions that are aimed to mitigate the complex conditions and should have certain characteristics, and they should have clear intervention targets, clear interventions and the clear intervention targets, and also they should be based on a very explicit theoretical underpinning, like maybe evidence-based medicine engraved into that. And also there should be element of self-management and a patient education, because patient education and the carer's education should be an integral part of the interventions that aim to tackle complex conditions. But then when you look at the society, and then you will find that there's an imbalance between supply and demand. And most of the interventions which are operating at the community level, you find that they are not catering for the demands of older people. So there seems to be a gap between the services which are provided for these people and the real needs of those people, and there seems to be an imbalance between a gap between the two. When you look at the core principles of a community-based care model, and there should be you should have what's called person-centered care, and that is very much talked about in the previous lecture session, and people talk about what's called person-centered care very much in focus now. And also there must be an element of what's called community engagement, where the local community get involved in the care process. The support of the caregivers and also coordination of the services and ensuring that there's a seamless transition between different care providers and the services. And then those are what are called the core principles of the community-based care model. Look at polypharmacy. And the polypharmacy is a real problem among older people, and lots of clinicians are quite ignorant about this. This is an example of where the patient with cardiac heart diseases, heart failure, and what the polypharmacy can do to them. And they can have a lot of symptoms like a dizziness and the bleeding. And we found one of the analyses that we did in our hospital, and we found the people are on what's called dual antiplatelets for long period, more than necessary, and then exposing them to what is called the upper GI symptoms. And also that people who have a tendency to fall, and there are high chance of getting a cerebral bleed. So most of things like urinary incontinence and then confusion, and all that can be sort of as a result of medication for polypharmacy and can be attributed to it. How we mitigate? Well, how to mitigate it? Well, there should be intervention. There should be strategies to prevent this. And also what people recommend is comprehensive medication review. And when you look at what the patient comes to clinic books, that you can see that no one has looked at the medication, the number of drugs and their indications and the way they were given. And then you can see that some drugs are running for years and years, and then the original indications, the patients have forgotten the original indications, and doctors have also forgotten the original indications. They just running it copied in page to page, so they are continued. So comprehensive medication reviews is very much required, and I don't think doctors are really geared for that. I just wonder whether it's because of the time constraints or simply because they are ignorance. My general idea is that it's a simple ignorance rather than time constraint. It doesn't take a long time for to see whether these particular drugs can be crossed off now and take into consideration patient's present condition. And deprescribing unnecessary medication, and lots of people have no sort of the guts to do that, confidence to do that, and then say that this particular drug is unnecessary and it can be struck off. And using tools such as what's called Beers criteria, fairly old, but again still in use, what's called Beers criteria, you have what's called modified Beers criteria, and also identify potentially inappropriate medications. And collaborative care with pharmacists, and also consequent patients' education, and utilizing electronic health records, and all that can be used in order to mitigate the problems with polypharmacy. And the only thing is that doctors need to be quite aware of the dangers that the polypharmacy can cause to patients. And the educate, there are many checklists what's called no tears, but I'm not going to go into the details of that. And there are many instruments that the doctors can fall back in order to decide whether this particular drug is any longer useful or not. Educating all stakeholders, and people have tried that, getting pharmacists, patients, and all the stakeholders involved in the learning process, educating people. And then this particular study published in 2022, I think, or 2022, and then the people expressed their what I call the views on the post intervention period, said that they have more confidence in discussing with people and the need of this particular drug, and all they express their kind of that the confidence after taking part in that particular study process. Then technology innovation, and then I learned that a little bit about 7 days ago when I was in Kuala Lumpur, and they had this particular conference called Precision Medicine in Public Health, and quite a nice conference that I attended about a week ago. And there they talk about what's called health technology innovations. And these are wearable devices and the AI-assisted tools. And they are reshaping the health, and particularly the older people, and because they can be useful in disease prevention, early detection of diseases, and also monitoring and access to care providers so. And the social life, they can stay connected with their loved ones and other people, and as a result, that can improve their well-being. So that's another aspect of what are called the health technologies. The continuous monitoring, and this is in contrast to what's called spot detection. Like for example, now people wear these devices and you press the button and it will give you the blood pressure and the pulse or the temperature at that particular time. And this is what are called the spot detection of this thing. But then the devices people are having, thinking of devices, and they are having continuous monitoring of their vitals like your blood pressure, pulse and temperature. So much before that you manifest your temperature, fever, that the system knows that you are developing getting temperature, because it knows your lowest and the highest temperature and the average and all. So because it's continuous process, and well before you know that you are getting an infection and developing fever, the device knows that you are getting an infection, so it can alarm you, saying that your temperature is going up. So these are what I call the beauty of these what I call wearable devices, which can do continuous monitoring. And also you can have remote patient monitoring, vitals, and also particularly arrhythmias, and also telemedicine, virtual consultations as highlighted in the previous lecture, and also eliminate the people need of travel, and also they are probably cost effective now, and also you can assess the best care options, because then you have access to let's say best radiologist and maybe somebody with the best opinion. The assistive technologies, they maintain improved independency and the safety, what are called smart wheelchairs, smart walkers, exoskeletons, and AI-powered fall detection devices. Medication management, because solution for the complex medication schedules, and let's say patient need to take, let's say, drugs 4 times a day, and then do it 365 days a year, and is an enormous task, and then people forget. So these devices can come very handy, because they can have what are called treatment schedules, medication schedules can be they can schedule it to the system. Smart pill dispensers, medication management apps are in operation. There are plenty in the internet if you want to go and see. Virtual reality is that the application which can improve physical and mental functions of people, usually computer based. And you can do simple tasks like catching the balls and as they fall, and then improve hand functions and all, and also they can improve mental functions. This introduction novel complex integrated care model supported by digital health intervention, DHI, and the European primary care setting, and then this when they highlighted their findings. And they say that's a multidisciplinary, which is a key word in geriatric medicine, multidisciplinary and also personalization of care. So this allows you to do a multidisciplinary perspective and personalization of care. And also they found that all the studies that they reviewed, they found that all the studies presenting statistically significant health outcomes and in these devices. So that's something. Shared care in all people. A collaborative approach where multiple individuals, often family members and healthcare professionals, share responsibility for an older person's care. It generally provides a more comprehensive and coordinated support, and then try to address both medical as well as social needs, and in their own home environment like. And what are the key aspects of shared care for the elderly? There should be a collaborative approach among all the stakeholders, and also it should be a shared responsibility. Like it's not that the doctor takes the responsibility of prescribing a particular drug, and it is a kind of shared decisions where the patient and the family members also part of that decision. It's not a complete let's say 100% decision of the doctor. It is kind of combined responsibility. And also focus on goals and preferences, taking into consideration patient's individual, personal kind of preferences. Interdisciplinary care, and improved outcomes, definitely lead to improved outcomes because people are more adherent to medication and then as a result you get more benefit. Comprehensive geriatric assessment, the role of geriatrician in shared care model, so he's the one who does the geriatric assessment and a specialized expertise provided to that team and then he's the one who's sort of leading from the front. Interprofessional collaboration between the, let's say, different stakeholders and the, let's say, nutritionists and all the other sort of physiotherapists and all that, he's the center man. And also care coordination and the transfer management and transfer between institutions and focus on function on the ability and the quality of life and the leadership and the mentorship and education and training. So geriatricians, 21st century, and should be sitting in the middle of that care team and doing all these things because he is the one who's responsible for that. So final conclusions are that the health needs of old people are very complex. And then they are not directly related to multimorbidity. So you can just treat the illness and then get away. You can't do that because there's going to be substantial interactions between many factors. And they need a coordinated care, which is multidisciplinary general, should be evidence-based and a patient-centered and also shared. The role of health technology and AI-assisted devices need to be understood because they are coming to the forefront in the management of these diseases and that the geriatrician can't be sort of ignorant about these and they should know the value of these things and they are not actually challenging, they are only complementing and to your care plan. They are consistently evolving and also they are challenged to healthcare teams and then in order to provide this better care. Thank you.
Thank you very much, sir, for the very insightful talk. With that, let me introduce the final speaker of the symposium, Dr. Chamila Dalpadal.